letting me.
Good morning. We have a lot to cover today. It is November 21st, and we had a request to also do some of what is happening at the state level. So we will be covering some things that are from the state legislature before moving to Congress, and then some of the things that the federal administration is doing. Some of the items that we're going to talk about at the state legislature actually relate to some of the activities that are happening at the federal level. You may remember last spring that the state budget process was ongoing, and many of you showed up at hearings or contacted your state legislators to let them know what priorities you thought that we should spend Wisconsin state taxpayer dollars on. And I have said this several times, but the disability community really turned out, and they talked about two issues. One was special education, and the other was Medicaid. And those two issues were the top two issues that state legislators heard about during the budget process as being important. So that's all on you. We had success on both of those issues. First of all, we had the Medicaid budget be cost to continue, which means that the legislature said we are going to increase the amount of money that we're spending on Medicaid so we can do the same things that we are doing now. And importantly, Medicaid is a sum sufficient appropriation. That's a fancy term that means we know we have estimates of what we think the cost will be. And if we are wrong in our estimates and the estimate isn't enough to cover what the costs actually are, if it is a sum sufficient appropriation, that means the legislature doesn't have to come back and act again. The extra money just comes in to cover those actual costs. So Medicaid is set up as a sum sufficient program. Many other programs have a different accounting code, and it's called sum certain. And that means that the legislature thinks about how much money it will cost to do a thing, and they set a defined pot of money to pay for those costs. And that works out okay if they're right on the estimates and the costs are what fit within the pot of money that they've reserved. If they don't, it means the legislature either has to take further action to approve more money for those programs, or those programs do not have enough to fulfill the legislature's intent, and they have to reduce, they have to figure out how to live within the budget that they have. And sometimes that means reducing services or wait lists or giving out less money to the entities that get money to do services. Long explanation. And the reason for that is because special education is a sum certain appropriation. And many advocates spent a lot of time this spring talking about how the amount of money school districts get back are reimbursed for money they've already spent on students with disabilities is far too low. And it has been very, very low for a long time. In fact, the legislature for the last couple budget cycles has increased special education reimbursement. And we've had a pattern where they make an increase, from 30 cents on the dollar to 33 cents on the dollar. And sometimes what has happened is that increase has not kept up with the actual costs of the services. And so they've added more money, but it isn't enough money to cover the actual costs. So despite their intent of increasing how much schools get back for money they've already spent, it hasn't worked that way in practice. And that is what has happened again. This Monday, the Department of Public Instruction calculated, based on the reimbursements and the actual costs that school districts are reporting, how far that pot of money that the legislature reserved would go. And it's a lot less than what the legislature thought and intended. As a reminder, we have our current reimbursement rate means that school districts get back 32 cents for every dollar they've already spent on students with disabilities. And that's important because public schools are required to educate students with disabilities. So when they don't get enough money to cover the costs of the students they must teach, then they have to find other places in their school budget to cut, or they have to go to property taxpayers again and again and say, will you please raise your own taxes, because the money that we're getting from the state is not enough to cover the actual costs of the school that we're running. So the governor proposed 60 cents on every dollar for school districts, and that it would be a sum sufficient appropriation. Remember, that's a big deal, because it means if we're off on our estimates and it costs more, the money is there. The legislature didn't do that. They promised a different number, 42 cents back for every dollar in the first year of the budget, and this is the first year of the budget, and then another increase in the second year of the budget. The intent was to get the reimbursement rate up to 45 cents on every dollar. But it's a some certain appropriation. And the way they calculate how much money goes into that pot is by looking at past costs. That doesn't tell you what current costs are. So it's difficult to look at what did you spend before and project what you should spend in the future, because there's always changes. There are either more kids that need services or kids that need different services. You know, it is an imperfect way to try and calculate, to look backwards to try and calculate what you should spend in the future. The Department of Public Instruction doesn't look at past costs. They look at actual costs. What are school districts reporting as the actual costs of providing special education services? And so when the department made its calculations looking at, here's the fixed amount the legislature approved, and it's their job to figure out how much does each district get, it isn't enough money. And when they divide that limited pot of money across all of the schools using the current costs, all of a sudden the promise of reimbursement of 32 cents for every dollar drops to 35 cents on the dollar, which is only 3 cents more than it was last year. So a number of school advocates noted this, and we put out a statement. You can access it online. And I think the action step here is, reminding legislators that this way of doing budgeting is consistently, cycle after cycle, we're not resulting in more support for schools or more support for students with disabilities. And that something has to change here, because we keep getting into the same position. And there's a point where schools need actual dollars to do the work. They don't need a promise that you can raise taxes if local taxpayers agree more. That isn't a guarantee of operating dollars. And this is just one example of how local advocates are identifying consistently a big need, gaining legislative success, only to have it kind of be wiped away because of how we've made the calculations of, how we base that money. In the context also of the federal landscape changing in special education, I think we've heard from a number of advocates that they are particularly worried that if we continue to not make gains at the state level, that the changing federal landscape may impact, students with disabilities and their ability to have support in schools. A second legislative update is actually an inaction. You may remember that the big federal bill HR 1 made many changes to the SNAP program, and it included some big cuts to the SNAP program, as well as new requirements for states that are now going into effect. We'll talk a little bit about those later. Mainly, there are many more people who will have to prove that they are working to stay in SNAP. And that means there's a lot more work for states to do to verify and prove that all of the people in SNAP are eligible to be there. And there is more cost when you have to do more work. At the same time, HR 1 also will reduce the amount of federal money that is currently coming into the state for the state to run the program. And since August, our Department of Health Services has said to the legislature, these changes at the federal level increased costs for us. At the same time, we're getting less money to help cover those costs, means we have a gap. It means the amount of money that the legislature gave to run SNAP isn't enough because of these changes. And they've said they need about $70 million more to implement these changes from the federal bill. The legislature has been informed and is aware of this problem. It has also been informed that there is some urgency here because there are now implementation dates from the federal bill that are in effect. October 1st was kind of the first wave. November 1st was the second, and we are now in November 21st. So we are actively in the period where states are now responsible for new requirements, and anything that isn't done right gets counted as an error. And HR 1 has financial penalties for states if there are too many errors. So many hunger advocates and other concerned groups, including the Grocers Association, who receive SNAP benefits, and aging and disability groups, have been saying there's a real need to act now. And the state legislature has said that they don't want to come in any more than once a month. So this week was the week where both the state Senate and the state Assembly met to do business. And this business didn't get taken up, which now means that we are in a place where we continue to have these extra costs and maybe accruing errors that will lead to penalties, and still no money to hire the extra workers who are needed to do the extra work. So it is unclear whether the legislature will meet in December. They are talking about January, but the longer that this inaction goes, the more likely it is that the state will be in a position where it is increasing its error rate and putting the state at risk for a financial penalty in the next budget cycle. In education, for those of you who receive our action alerts, you will have gotten a detailed action alert, I think twice, about these two bills that essentially make it easier for teachers to take students out of classroom if there is a disruptive incident. And disability advocates showed up at the hearings to explain that why we think this will cause the removal of many more students with disabilities, even more so than already occurs, because Wisconsin has a fairly broad, you know, it's fairly easy to get excluded from our classrooms in this state. And so you can read our testimony on these bills and watch Wisconsin Eye for the hearing if you would like. But these bills passed the full assembly yesterday, which means that no, there's no action in the Senate, but it's a good opportunity if you are inclined to read up on these bills to contact your state senator for sure and say, hey, these passed the assembly, but we don't think that this is going to result in good things for students with disabilities. You've also maybe received action alerts on a different bill called the Patients Representative Bill. And this bill had a public hearing in the Assembly. It was not on the schedule for this week, but advocates from Aging and Legal and the Counties Association and disability groups, as well as social workers and others, have a lot of real concerns about how this bill could put patients at risk of a financial or other abuse. And we do not think it will actually solve the problem that's seeking to of more quickly transferring people who are medically incapacitated out of the hospital to somewhere else. So I've included a link to the memo that a number of groups sent to the legislature, and there are others that sent independent letters as well as our testimony. I think the important piece here is that legislators really need to hear from family caregivers and individuals, that this is a risky thing to do for lots of patients. And the governor's office is especially important to contact the governor's office on this as well. If you look at the ION lobbying site, you can tell where a lot of organizations stand. It really is very one-sided, that you have healthcare organizations that are supporting the bill and everyone else from a wide variety of vantage points is saying, we don't think this is a good idea. There's also been a lot of activity on voting bills this week. There are two bills that are of particular concern to people with disabilities. Neither of these bills were on the slew of bills that the Assembly just passed this week related to voting. So in that sense, it's a good sign that these were not included amongst a larger package of bills that would change how the voting process is done and other things. We're highlighting these two because we think they disproportionately impact people with disabilities more. And we sent out a press release about those bills, but since they are not were not voted on by the Assembly, there hasn't been an action alert sent out. However, there are Senate bills that are kind of the companion to these two that are coming out and may have a public hearing. And these two bills did have an Assembly public hearing that was held, so they could be they could be pulled and voted on to the floor. So be aware that there in this state, as there have been for the past several sessions, there are many bills related to voting that we are keeping an eye on. And I will probably send out an alert on Monday, just kind of summarizing the bills and the action steps that you can take. But here's a slide that kind of tells you, where are things in the process and where are who do you appropriately contact if you have thoughts about these bills. Another thing, remember all of that, take the survival survey on caregiving. we finally have the survey results ready. And they are pretty powerful. So if you are looking for other things to talk about besides all of the things happening at the federal level and state level, this is a really, I think, a good product. There's a link to where you can find and download the full page. I've kind of just clipped here the highlights. It's a one-page front and back. And I think one of the best uses for these kinds of products is to take it with you if you're going to meet with your legislator at a coffee shop or an office, or you're going to send an email and just say like, hey, I'm not alone. This is me too, and let me tell you your story, my story. So we had more than 525 people across the state take this survey, and I think there are two things that are really powerful for me in this survey. First is the amount of people who are doing enough caregiving where it's a half-time or a full-time or a more than full-time job in and of itself. And then the number of people where if there isn't a family member who is filling in those gaps of care when they happen, how many of them go without care at all? It's pretty high. It's about a third. We also asked in this survey, what are caregivers doing? I think this is an important part of the story, and an important part of when you're using this sheet and telling your own story, kind of saying, hey, this is what caregiving means, because many members of the legislature don't quite understand that caregivers are performing some pretty complex medical tasks sometimes, as well as really hard administrative stuff. And so the more that we can say that this is a universal experience and that you can add your experience into that, I think the more real the scale of this problem becomes for state legislators. So again, the link is here, and we will probably send out a special message again next week just to release it, so you have that in your queue. Moving to Congress. All we're going to say about this slide is that there is less time than there was last week to do all of the same things that we talked about last week, which is passing the remaining 9 federal 2026 appropriation bills and figuring out something about the ACA marketplace subsidies. Congress has gone, the Senate has already gone home for Thanksgiving break. So next week, Congress is not doing anything, which means that when they come back, it will be the 1st of December. And you can see how little time there is between the 1st of December and their next scheduled break of the 19th to get all of those things done. The impact of the shutdown has actually not stopped for states. And there is some, every state made different decisions about what to do as various pieces of federal funding weren't coming in or were delayed or were deliberately stopped. So the continuing resolution did say that states will be reimbursed for money that they laid out to keep things running that would have been paid by the federal government. However, the relationship between states and the federal government has been strained by recent actions. And lots of states are nervous about how is that language going to be interpreted, and will it be interpreted in a way where states who in good faith laid out state funding to cover costs that had been generally paid for by the federal government, will they decide or not decide that it meets the criteria for reimbursement? The other challenge that is ongoing, it's not only the shutdown, but states are kind of looking at the recent behavior of the federal government And I think it is causing a lot more uncertainty as they think about their own state budgets and planning for the future. Certainly HR 1 makes some pretty deep cuts, and we have spent a lot of time talking about Medicaid and SNAP in particular, which are big parts of a lot of state budgets. But there are also a lot of tax code changes that happened as part of HR 1 that may impact how much money states are receiving, revenue. And that may actually decrease the amount of money states get in and kind of add to state budget woes in the future. Colorado is an example of a state where that already happened, and they had to kind of make a number of cuts, and they did make some cuts to Medicaid in the summer in response to those federal tax changes. They're kind of unique in that there was an immediate impact, and now they're in their second rounds of cuts and making more cuts to Medicaid. But that is something that all states are thinking about. Moving towards the federal 2026 appropriation bills, there are 9 left. We will focus on 2 that have the most importance for people with disabilities and older adults. And those 2 are the Labor, Health and Human Services and Education budget. And you can see, just how many things are under that budget. And then the Transportation, Housing, Urban Development budget bill is its own bill. And there's really 2 critical areas within that one. Both of these bills have had a version approved by both the House and the Senate committees that deal with the bills. So there is some alignment in some ways where there's been movement by Congress on both of these appropriation bills, and they are being listed in Senator Thune's package of the next 5 appropriation bills that he wants to move forward and deal with. Also importantly, neither of these bills reflects the president's proposal that would have made major changes to eliminate funding for certain programs or certain agencies or consolidation. So both the committees at least have said we are using the same funding structure that we have used in past budgets, and we are not making any changes to the appropriation lines or the programs or saying that we are going to try and figure out how to do what the president has proposed in his budget in May. That is an encouraging sign that there isn't structurally a change. Both of these committees have committee reports that are not legally binding, but that have a lot of language about what Congress intends to fund. And those reports are somewhat encouraging, especially on the disability side, that Congress, especially on the Senate side, is saying, we intend to level fund all of the disability programs in the Administration for Community Living, which again, you might remember in the spring was eliminated, administratively. Neither of these bills agree. The House and the Senate versions do not agree. And the language has to be the same in order for the House and Senate to pass them and have them be signed by the president. So there will be changes. The committee is kind of the legislative experts on these particular bills. What the committee says matters, but it is not the same as all of the members of the Senate say, or enough members of the Senate or enough members of the House agreeing with the committee's recommendations. So we shouldn't look at the encouraging signs in the committee and say, well, that's what's going to happen. There will be changes, but we are in a better position than we would be if the committee had made very different recommendations. So again, we have December Senator Soon has said he wants to move 5 appropriation bills, including these two, by the end of the year. Remember, the continuing resolution expires January 30th. So if they don't get it done in December, technically they have, several weeks in January where they could act before we get to that January 30th deadline. But still, it's not a lot of time to move big pieces of legislation. The other big thing Congress is dealing with are the coming expiration of the Enhanced Affordable Care Act marketplace subsidies. Those subsidies are going to expire at the end of the calendar year, so December 31st. And we've spent a lot of time discussing those subsidies. Obviously, the open enrollment period is now open. Some states have a deadline of December 15th for people to choose a marketplace plan. And the big news is that Congress made a choice to not extend the subsidies in HR 1 that did all the other tax stuff. And they made a choice to not do that through the continuing resolution or independently thus far. And now we are deep within the open enrollment period, to the point where many watchers say, even if the subsidies were extended as they are now, states would really need to scramble to be able to help make it happen and give folks who are shopping for plans certainty about what their premiums and their costs would be. So the Democrats have kind of one position that is unchanging. They want the subsidies extended exactly as they are now, and they were promised a vote in December on a bill of their choosing, and that is likely to be what they're going to choose to do, and it is likely that that will fail. That is not different than what we've been talking about for weeks. But this week, there are a number of new ideas that are not about changing how the subsidies work, but are about not doing subsidies at all and doing something different. And I've kind of laid out kind of the positions, and you can see, especially in the House, that there is a lot of variety. Everything from just let them expire and maybe don't do anything, to let's change the current subsidies and maybe there will be fewer people who qualify, or there will be extra requirements. And we've kind of talked about those ideas before. To now, let's redirect the subsidy money to individual health savings accounts and just give people a lump amount to spend on their health care and be done. And we've talked about, there's a number of articles here about why that wouldn't necessarily work. It would not lower costs for consumers of healthcare, but it is an old idea. And if you were looking for a deep dive about how this old idea has worked in practice, it's actually been tried before in the past few decades. And some of what we are actually used to now, this idea of consumers having more skin in the game, those higher out-of-pocket costs like co-pays and deductibles, etc., that is one form of this idea of make sure that consumers have some amount of their own money at stake, because the idea is we believe they will make different and lower cost choices if they have to pay for some of those choices. The evidence does not show that that actually works in practice for a couple of reasons. Shopping for healthcare isn't a reality for most patients. There are limited provider networks. Many insurance companies or healthcare providers have gotten bigger and bigger and bigger, so they have more of the market share, or they've acquired maybe the entire supply chain that a patient needs. So there is a lot less competition. Patients don't know what their doctors are going to recommend, and they don't know if there is a cheaper option or if they can or should refuse a test that's being determined to be medically necessary. So there's a lot of reasons where this idea of just having, forcing more choices onto the consumer doesn't really work in practice. And lots of experts are saying, well, this idea of just giving folks a lump sum of money doesn't actually address higher healthcare costs, and it doesn't necessarily mean that people get enough money to cover what they need. So, questions you can ask Congress. It's still worth asking, what do they think about the ACA marketplace subsidies? And if they don't want to extend those subsidies, then there's another set of questions. Because for 15 years, we've heard from some members of Congress that they don't like the Affordable Care Act. And yet we also have not heard many details about what their plan is that is different and how it would work. So if you have a member that says they don't want to extend the subsidies, or they want to do something else like health savings accounts, etc., it is always worth asking, well, how does your plan actually address the problem that you think it does? Rising healthcare costs. What does it do to make sure that the costs are actually lower and that I have access to what I need, and that increased costs aren't being passed on only to me, the person who's trying to acquire care? Other questions for Congress related to the federal 2026 appropriations. Some of these are familiar to you. Sometimes asking the same question is the right thing to do because the opinions of Congress keep changing. In this case, there's now the administration is now saying, hey, we're going to move Department of Education programs to other departments, and we're going to make changes that might impact who gets the money and how it's used. An example is the housing grants that we've talked about a couple of weeks. So it is now an appropriate question to ask Congress, are you going to do something about that? If you're putting in a budget plan that shows, these agencies and programs are funded at certain levels, how are you going to make sure that the program is implemented with fidelity, that it's going to keep running with the same outcomes that we are expecting now? Moving to our administration, we're going to start with a little bit of a yay here. For the last few months, we've been following a proposed rule change that the first Trump administration wanted to do, but it didn't end up having enough time to implement. And I think we just talked about it a couple weeks ago. Because of advocate uproar and people like yourselves, the idea of removing age as a factor to consider when people are applying for SSDI, that's been scrapped. And lots of people thought that idea would mean many, many people age 50 and older would end up not qualifying for disability and potentially having to take a lot less money and retire early and go into Social Security. Remember, the disability fund is kind of separately funded from the retirement fund. And the more people who are relying on the retirement fund, faster that's depleted, while the pot of money that's reserved for disability remains untouched. So there were a lot of concern that particular change would really mean that a lot of people who should have qualified for disability would have been denied, and then what would happen to them after that. It's kind of a mixed bag because there was another change that was going to be proposed that is now also on hold. For the last several years, there's been an effort to update the outdated jobs database that was used to help determine whether somebody who was applying for disability SSDI would qualify. And a lot of the jobs that are on that outdated database really don't exist in the real world anymore, like nut sorter and telephone code operator and other things. So there is a need to update the database, and that is now on hold. But it's something to watch because again, depending on how they redo what jobs they think somebody could potentially do impacts whether or not they qualify or don't qualify for disability insurance. And there are disability advocates that are worried that the new database could be kind of programmed to come up with lots of different things that the agency could say, well, you're not disabled enough because you can do this kind of job, as a way to deny benefits to lots of people who are applying. However, the removal of age as a factor in disability was so potentially harmful that most advocates are saying we're going to take that win as being a major win, and then we're going to continue to worry about this second part later. This week, there's been a lot of coverage of the Trump administration's announcement of a plan to eliminate the education department. And we've talked about some of the worries and that national advocates have about what would happen to IDEA implementation and money flowing to states, and also the expertise that's currently in the education department. It remains uncertain that those folks in the education department who were fired October 10th and now reinstated and now have their jobs guaranteed by the continuing resolution through January 30th, there's still a lot of layers of chaos, frankly, that make it hard to know whether those people who are experts will actually move with the programs. And interestingly, this is not a new approach to dismantling an agency that bypasses Congress. So federal law directs certain programs, including IDEA, and funding to be administered by the Department of Education. And this plan would say, okay, we aren't going to eliminate the department on paper, but what we're going to do is use something called an intergovernmental contract agreement to basically decide that we're moving functions of the department to other federal agencies. So in other words, the Department of Education might exist on paper, but everything it does would be done by a new agency, and who knows if the workers who are currently doing those jobs would move with those functions. This is very different. There are agreements that federal agencies and state agencies too have for certain things, but they're usually very narrow and very task specific. So perhaps there's an agency that kind of has all a domain over a certain kind of information that's useful in a project. And maybe another agency says, hey, we really could use this for that project. Can you help us? That's the kind of narrow agreement that is usually used. This is something different. This is moving entire programs and functions from one agency to another, and to an agency where that is not their expertise in their charge under federal law. So there is currently no plan, there were 6 programs identified as moving, mostly to the Department of Labor. Some education programs focused on Native Americans moving to the Department of Interior. There have been plans, at least in Project 2025 and the president's budget, that special education would move to the Department of Health Services. There's no agreement yet to that effect. But they aren't ruling out moving those, either the Office of Civil Rights or the Office of Special Education to someplace else. Interestingly, we had a grassroots person share a response she got from her Wisconsin member of Congress last week that indicated, and she had contacted them about her concerns about the education department, that indicated that special ed would be moving to DHHS. So it's very unclear how much of this is just not announced yet or might change in the future, but it's certainly something that advocates are watching. Another announcement, to which there is no formal plan yet, but this was said this week, that the USDA secretary intends to have everyone reapply for their SNAP benefits. There's no timeline. There's no when or how people would need to reapply, or whether or not the requirements for reapplication would be different. It's simply a statement. However, it does convey a certain level of intent. And, many states already require SNAP participants to kind of re-up their information every 6 months. And there's a lot of paperwork that SNAP recipients already do. Again, the rhetoric, if you wanted to dig deeper into this article, really is focused on this idea that there are 42 million households who rely on SNAP, and that somehow that is too many. And that we want to make sure that only people who really deserve SNAP get it. And this assumption that there can't be 42 million people where that's the case. This has kind of been a recurring theme of how, since March, really, about where is some of the data that federal agencies have had kind of their control over. How is it being used, and how is it being used by other federal agencies for purposes for which the data was not collected? So this was an article in Wired, and that kind of proves what we already suspected, that Social Security data is being used now by the Department of Homeland Security. And the other important nugget here is that Social Security, it used to be that the only way you could deactivate somebody's Social Security number was if they were dead. Deactivating a Social Security number is a big deal, because it really means that you kind of cut off somebody's financial life. They can't work without that number. Lots of things can't happen without a Social Security number. So deactivation is a really big deal, and it sometimes has happened by mistake, and it's really hard to correct. It takes a lot of time. But now it appears that maybe you don't have to mark somebody as dead to flag a Social Security number and stop that person's financial life. So now there is apparently a code that identifies certain kinds of data or circumstances that flags that Social Security number, and it's being used to flag people whose citizenship status is unclear. The administration has been really clear it wants to create a national citizenship database, and specifically has been looking at different types of programs that are kind of lumped into public assistance, includes housing and SNAP and Medicaid. And the Department of Homeland Security has looked at the Social Security Administration as being the largest set of citizenship data that any government agency has. So having access to that data is a pretty big step towards this larger goal of how do we know who's a citizen and, what are they using in terms of government benefits? How are we tracking these folks? But Social Security data isn't a good source. It shouldn't be used for citizenship purposes because they don't actually confirm that citizenship data status with certainty. They don't have complete information for everybody with a Social Security number. There are some indications of who's a citizen, but it's not necessarily absolute proof. And it was never collected with the goal of being used to determine somebody's citizenship. There's lots of mistakes. There's lots of mismatches. Whenever you start marrying different data sets, you get duplicates, you get people with similar names, you get people who have moved or changed addresses, you get people who weren't citizens who become naturalized or become citizens later. And all of those mismatches, especially when data across multiple systems isn't up to date, means that people who are legally here or who are citizens of the United States could get caught up, determined to be not citizens, and then have consequences happen to them without knowing why, including deactivation of a Social Security number, but also it could impact your ability to vote and work. In addition, we talked a little bit last week and the week before about public charge rule coming back. This week, the administration announced it was doing something slightly different than re-upping the rule itself. And instead of revising the formal rule, that they want the Department of Homeland Security to release guidance, and there's no date on when this guidance comes out, and use the rule, the kind of this approach to give immigration officers the authority to deny permanent residency to lawfully present immigrants who use Medicaid or other food and housing assistance. And the idea is that anybody who's coming into the country who is at risk of maybe becoming a public charge, in the opinion of an immigration officer, could be denied entry. That applies to their larger family as well, and disability is family members, weight, other medical health conditions are all factors that are being used to determine whether somebody is at risk of being a public charge. Interestingly, the administration is projecting, well, this could save us almost $9 billion annually because people will drop out of Medicaid and other benefit programs. And they seem to recognize that could be people who do not have, who are the immigration status, as well as U.S. citizens who are members of mixed status households. Yesterday, the Centers for Disease Control changed its website to basically indicate that there is uncertainty on whether vaccines cause autism. The previous version of the website was very clear that there was no link between vaccines and autism, and cited the many studies that have been done over decades now that prove that theory. Thursday, the webpage was changed to say that the claim that vaccines don't cause autism is not evidence-based. There are studies that say the opposite, and there's a handful that are from long ago, and that because we haven't ruled something out with 100% certainty, we shouldn't say that that the overwhelming amount of evidence that exists is true. There's been 30 years of studies that have consistently not found any connection between vaccines and autism. I think the important, bigger piece of this change is that now this is different in the sense that this is a formal Centers for Disease Control website that is now changing information to fit a political narrative that may have a desired outcome about vaccines, and folks with autism are kind of in the center of it. This is disinformation, which we have not seen our government do before. And it is a pretty significant change when people who might look to a government website for guidance or for some sort of true information are now being told something that is very much contradictory with what was true and has been posted, yes, like 2 days ago and many years before. Just briefly, as we think about changes to the Affordable Care Act subsidies and maybe them not being in existence anymore, and other ideas about what to do instead, it's worth noting that the administration has been promoting short-term private insurance plans as an alternative to ACA marketplace plans. And as you know, people, we've shared before, okay, how do you shop for ACA marketplace plans, what to look for, etc. There may be people who are tempted by these kinds of plans that the administration is really recommending. But there are some real risks to them, and this article does a pretty good job of highlighting what that is. These are much cheaper plans, but they aren't required to cover pre-existing conditions or even basic things like prescription drugs. So, and the deductibles are really high. Like 60% of costs are covered, and then you have to cover the remaining 40%. So people who end up with bills like for surgery or other things can end up hundreds of thousands of dollars in debt very, very quickly if they have one of these kinds of plans. So as you are talking to your friends about what to do, if you're in the marketplace looking for other things, just know that there's some other plans out there that look cheaper, and they are in terms of premiums, but they also aren't required to meet the standards of the Affordable Care Act, and they could end up costing you a lot. All right, moving on to the fallout from the reconciliation bill. Some months ago, it was pointed out that the amount of tax cuts that were included in the bill were so large that it would trigger another law that would require across-the-board cuts, and that would have impacted Medicare. It would have required a cut of about $500 million unless Congress did something. It turns out Congress did do something in the continuing resolution to avoid and kind of ignore that law, that PAYGO law. So there will not be a $500 million Medicare cut. That was one of the things that Congress had to decide. And also the continuing resolution restarts the ability for providers to be paid for telehealth and hospital at home. Telehealth has never had formal legislation to make it okay. For some reason, it's always been in a continuing resolution. So when the federal government shut down, the ability to pay for telehealth shut down, and a lot of people experienced their appointments being canceled. Now we have another continuing resolution, so it's back up, and back up until at least January 30th. And then going forward, assuming that we have appropriation bills that advance, we're hoping telehealth will be continued through the appropriations process if there is no legislation to formally say, yes, we can pay for this. Moving on to SNAP again, we've talked about how some of the provisions in SNAP are now in effect, that there are new groups of people who weren't required to prove they are working before who are now. There's another provision within the bill that says, hey, if you don't prove that you're working enough, we give you 3 months and then you lose your ability to get benefits entirely. That's another provision of the law we haven't talked as much about. So not only do people who currently have to prove they're working, but new people who have to now do that requirement, they have to know about it and they have to complete it correctly and on time and be working enough to avoid, the potential of losing their benefits in 3 months' time. This article basically says there are a lot of people who might not be able to do that. And so the 3-month time, they may be on a 3-month timeline, which they may or may not be aware of, where they stand to lose their benefits because they haven't met these new requirements. Another impact that's in effect is that there are lawfully present immigrants who have been SNAP recipients in the past that are no longer eligible, and that is effective immediately. So we could see that 42 million number of households in SNAP really start to go down in the next few months because of these new provisions. Another success, we followed North Carolina in the past. Remember, North Carolina did not do what Wisconsin did. They did not put enough money into their state budget to continue their Medicaid program as it is now. So they kind of caused cuts before HR1 is going to cause cuts. And some parents with disabilities sued because the way that North Carolina reduced their Medicaid budget to make up for the shortfall the legislature caused is to make across-the-board provider rate cuts. And some of those rate cuts were more than 3%. It was between 3 and 10%. And it included cuts to ABA services for children with autism. So these parents said, hey, that's discriminatory, and they won a court case. And that means that that temporarily restores funding for this kind of autism therapy because parents said, hey, these rates are really disrupting not only our care, but are running up the risk of institutionalizing these particular children. New Hampshire is starting to think about how to implement the work requirements in HR1. This is a legislative committee, so not the full New Hampshire legislature yet, but worth noting is that this is an example of a state that is taking what the federal baseline of what the prove your working requirements require and going farther than the federal requirements. So one way they are doing that is saying the federal requirements say you have, if you're the Medicaid expansion population, New Hampshire expanded Medicaid, Wisconsin did not. So this applies to their expansion population. One of the requirements of HR1 was the expansion enrollees have to prove that they're working enough every 6 months rather than every year. New Hampshire says, no, we're going to do that quarterly. That means 4 times a year. Those people have to prove that they're working enough. And they're also doing something where they're not allowing people to self-attest that they're making work requirements. Instead, they are the bill as it is written would require formal documentation. That's really problematic for a couple of reasons, because there's a variety of ways to meet work requirements. If you are working 80 hours a month, then it might not be, that's easy. But you can also be working or going to school or doing certain kinds of volunteer activities. And even people who are working, if their shift hours are changing or they're working multiple jobs, the question of what is formal documentation, especially if you have to collect it from multiple sources, becomes complicated. So that is one thing that becomes a barrier to meeting the requirements. Even if you are meeting the requirements, that proof becomes the determination of whether or not you have done enough to keep your Medicaid coverage. This plan hasn't been approved yet, but those two things are important to note, as states are all going to start making different decisions about how they're going to comply with these requirements, which, by the way, CMS has not offered any guidance to states about yet. And lastly, again, HR 1 cut a lot of money from Medicaid, $1 trillion, and we've spent a lot of time talking about the impact on rural healthcare, because so many more patients are on Medicaid, and there are, those hospitals are challenged financially anyway. And there was so much discussed about the fate of rural hospitals that actually Congress said, well, yeah, we should put a $50 billion fund, and we've talked about how that fund actually isn't going to really help them, but put that aside, specifically for rural hospitals. Here's a new analysis that says that a lot of hospitals that are most at risk of closing services or closing altogether are maybe in cities. And the characteristics that they're looking at are any places that have already fragile finances and where a quarter or more patients rely on Medicaid are at risk. And when they look at those two criteria, 85% of the hospitals were actually in urban areas. So that just kind of tells you that there isn't a geographically safe place to be from these cuts, and that these cuts are going to impact lots of different care settings, both in rural and urban communities. Lastly, just another article from our folks in Wisconsin, and I encourage you to read it. This is really illustrating how families are thinking about what is going to happen if we can't get the same things that we have now. This is a couple who's working. Husband has insurance, employer-sponsored insurance, but Medicaid picks up all of the things the employer-sponsored insurance doesn't, for a kid who has some pretty ongoing needs. So feel free to read it, but I think it may match the experience of a lot of folks that are around the state, of thinking about what are we going to do and how do we plan in a time of great uncertainty where everything is pointing to we may not have the same supports that we have now. With that, I am going to stop sharing.
All right, we had no questions. Tammy, you're just so thorough. No questions at all. Just for everyone on, we do have a survey, an annual survey that BPDD does, and it's really important for us to gather information from you about the work that we're doing. So I put those links to the survey in the chat. You can grab them before you get off. We'd really appreciate you filling that out. It helps for our federal reporting on how we are serving the public. So that's all I got.
After message coming out this afternoon. No webinar next week. Happy Thanksgiving. Celebrate hard. Back December 5th. So we will get a registration for that. And look for some action alerts in your inbox next week. Not only on the whole collection of state bills that we're following, but also a special message on that Survival Coalition survey that you can share out with others.
Awesome. Great. Thank you. Thank you to our interpreters. Everybody have a great Thanksgiving. Bye-bye.